Linda O'Reilly recently retired from her role as nurse practitioner at UMass Memorial Healthcare in Worcester. She also worked in HIV service at Fitchburg Community Health Connections. She received her nursing diploma from Dawson College in Montreal and her bachelor's in nursing from the University of Calgary. She completed her master's in science and nurse practitioner at UMass Worcester and her postmaster's certificate in psychiatry from UMass Lowell. Linda worked with the HIV program at UMass Memorial Healthcare since 1993. She served as a consultant care nurse practitioner for persons living with HIV and TB. She provided consultations for post-exposure prophylaxis for occupational and non-occupational persons exposed to bloodborne pathogens. Linda also consulted on psychopharmacological management for patients with mental health issues. Her experience in caring for those with PTSD began as summer employment in extended care facilities as a student. This experience has been invaluable in caring for people living with advanced HIV and AIDS. And along with many of you, she has seen a beloved colleague who struggles with PTSD symptoms.
Thank you all for coming out this evening, and I hope that the nice air conditioning is a breath of fresh air for you. It's pretty sticky out there, I know, today. So we have a couple of hours to talk about HIV this evening. And actually, this slide's already outdated. We've just passed the 45th anniversary, as we'll talk about, because it was 1981 when the initial reports first came out, and I'll show you what those reports are. So my plan is, back up. So just taking a look at the history of HIV, because it is very complex, and I've been privileged to be a part of that for a very long time. We'll take a look at the pathophysiology. You probably all heard this before, but just as a quick refresher, because that will help you understand what we're doing in terms of treatment. We can look at how the treatment has evolved, take a look at special populations that we're working with in terms of dealing with HIV, and then look at HIV prevention, which was a huge chunk of what I was doing in the last few years. And then take a look at why don't we have a cure? Where is it? Where is it out there? Because all the time, I was hearing from patients like, we know there's a cure and people are only in this to make money. And I'm thinking, yeah, no, I don't think so. The insurance companies are paying gazillions of dollars for hospitalizations and labs and medications and so on. And believe me, if there was a cure out there, we would have it by now. So just the conflict of interest statement, I don't take money from any pharmaceutical companies or medical device companies. I've researched the program independently, so what you're seeing has been researched. There's a bibliography at the end if you want to go on and do further reading on your own. So as I was saying, this was the first report of what came to be known as AIDS. It was June 5th, I believe. June 5th, 1981. And it was a report of young men who had pneumocystis pneumonia. They also were found to have CMV infection, cytomegalovirus infection. I'm just going to turn this a bit so I can see what I'm talking about. There's a concept. And they also had oral candida. So this was June 5th. 4 weeks later, on July 3rd, we had 26 cases of Kaposi sarcoma, which was very rare to be seen in those days in young men. Usually if you saw Kaposi's, it was in elderly gentlemen of Mediterranean descent. And it was very slowly progressing, it was cutaneous. But these young men had a mucus presentation, so it was blocking off their esophagus, their intestines, that sort of thing. So it was called gay-related cancer, GRID, gay-related immunodeficiency, and it was mistakenly believed that you could only get it if you were gay, which is kind of bizarre, but looking back at it now, but that's the way people thought. So in addition, the following year, 1982, we've gone from just a few cases to 771 cases. And then HIV was found to be associated with other groups and not just the gay group. So this was what they called the 4-H club. So it was homosexual, Haitian, hemophiliac, and heroin users. So that was, if you think of it, those are all the ways that HIV is spread, not being a Haitian, but because Haiti at that point was a very open community and people went there a lot for vacation. There was much engagement in sexual activity with the local population. And unfortunately, Haitians were unjustly singled out as being part of the risk group. And then we found that it was spreading into countries in Africa. Women who were the partners of men who had HIV infection were identified as being at risk also. And you can see, look at the number of cases that have jumped substantially. We're now up to 2,800. And those are only people who were identified. And so you have to realize that if you were sick enough to have AIDS in 1983, you probably had had the virus for a good 10 to 15 years before you started to get sick. So this was not a phenomenon of the 80s at all. It was an identification in the 80s, but not a phenomenon of the 80s. This was more like the 60s, the 70s. And in fact, the very first cases were found from people who had been working in Africa in the 1940s and the 1950s. So 1984, we finally have a name for this creature. We finally have some idea of what to call this and maybe take a look at how to deal with it. And they decided to call it HIV eventually, but it went through any number of sort of name combinations and permutations before then. But now the cases have jumped, almost an 80% death rate. They started to do contact tracing. And so what they did was they identified one person who could be linked to multiple other people, and just to try to figure out how HIV actually was spread in the community. So if you take a look at the person that, this is just one person that they've chosen to do this, this slide on. But if you take a look at the person who's identified as patient zero, ground zero sort of thing, and you can trace back the primary contacts that he had, to the secondary contacts that he had, to the tertiary contacts that he had, and then all of the different HIV-related illnesses that he had been in contact with. You know, it was Kaposi's sarcoma, pneumocystis pneumonia, those are kind of the two biggies, really. But then other opportunistic infections, it could have been Mycobacterium avium, it could have been toxoplasmosis, cytomegalovirus, retinitis, any of those things. So they began to do contact tracing in that way, just to try to track where the virus might have been spread, and also to track the kinds of opportunistic infections that were being exhibited by people who had profound immunodeficiency. So moving on then to 1995, this was where little Ryan White was booted out of school because he was found to have HIV because of clotting factors that he received to treat his bleeding disorder. And then Rock Hudson, of course, died that year. 1986, this was the first year, the first panel of the AIDS quilt. The first panel right here is Marvin Freeman. And then this whole sort of panel was all put together. I've sort of included the names of some people who have died that year that you might know. Perry Ellis was a clothing designer, and Jerry Smith was probably the first professional athlete to come out as having HIV. He was a football player for the then Washington Redskins. And after he left football, he went and he opened a bar, and it was sort of a gay haven, and he acquired AIDS and he died as well. So if this was the first year, the first panel for the AIDS quilt, in 1987, AZT was finally approved. So we are talking 6 years out. We finally have a possible treatment for HIV. It's finally been approved. We now can offer people latex condoms as a possible protection against HIV. There is a ban on HIV-infected immigrants and travelers from coming into the United States. And the AIDS Coalition to Unleash Power, ACT UP, was founded in New York City, and they were pretty integral in pushing for medications to be researched, to be developed, and finally to be made available to people with HIV. And this is a picture of the AIDS quilt on the National Mall in Washington. It's considered to be the biggest piece of folk art in the world, and now is actually too big to fit on the National Mall all at the same time. And these are some squares of some of my patients. And if you wanted to do any looking up into the AIDS quilt, you can go to this website here, and you can pull in a square number, you can pull in the person's name, and you can see who is represented on the quilt. And I put these ones up. These are patients of mine who were very vocal advocates for HIV care and education, so I think they would not mind their names being up there for you today. We're now piloting needle exchange in 1988. This is really important here, looking whether AZT can prevent maternal to child transmission, starting with simian immune viruses in monkeys, because of course we're only a few chromosomes removed from our monkey cousins, and as we'll see, HIV is posited to have been a mutation from the simian immune virus. So here we have some of our friends from ACT Now who have chained themselves to a fence, and they are finally pushing for additional treatments. There's new treatments for managing AZT-induced anemia, community-based research program units, and the death toll continues to rise and the number of diagnoses continues to rise. The ADA Act now is preventing discrimination against people suspected of having HIV, because remember, in the early days, people lost their insurance, their jobs, their housing. They were run out of town on a rail. And now we have some form of legal protection, although discrimination is very insidious and it still exists. Ryan White died that year of AIDS-related consequences. Keith Haring, an artist who did a lot of work promotion for HIV education, also died that year. And this photograph was on Life magazine, because people didn't really know what AIDS did to a family and to an individual. And there was, I guess, a big discussion, should we show this family in their pain and this unfortunate gentleman dying of HIV-related causes? And they decided to go ahead and do it because they made it real for people, to see that this is a tragedy that affects everybody. So now we are looking at 1991. 1 million Americans are now infected with HIV, 10 million worldwide. Magic Johnson announces that he has HIV. Freddie Mercury dies. And we are now looking at different surrogate markers of efficiency. How well do treatments work? Treatments, the original markers as to whether a treatment worked was either you died or you got better. But now we are looking at different markers to see how well treatments work. So those would be some of the lab values that we're going to be talking about. And this is the first clinical trial of combination therapy. So in 1992, we actually had 2 medications to treat HIV that were licensed. And we are looking at many others in clinical trials. And part of my job actually was to be a clinical trials coordinator. So it was really exciting to see all of these new medications coming down the pike and seeing how effective they were, what were the issues with them, that sort of thing. So sexual transmission, the leading cause of HIV among women, because the recipient of vaginal sex is at much higher risk than the person who is the inserted person. Tom Hanks wins an Oscar for his role as a gay man with AIDS in Philadelphia. I would recommend to you a slightly earlier movie called Longtime Companion. And it looks at the early days of HIV among a group of men living in New York City. One of the actors in it was actually nominated for a supporting actor Academy Award, but he didn't win because Hollywood had such fear of talking about HIV at the time. Let me see. Arthur Ashe was the tennis pro who got HIV through a blood transfusion, and when he died, he did not want it hidden. He said he wanted to be out there, he wanted it known. It can happen to anybody through a blood transfusion. Unlike Isaac Asimov, the science fiction writer whose family said he had cancer, but he also had AIDS that he got through a blood transfusion. And then Nureyev died. Now we're looking at AZT can reduce the risk of mother-to-infant transmission. And this is really exciting because the risk to women having a baby with HIV before then was devastating. So many women had tubal ligations, abortions. They could not fathom the idea of bringing a baby with HIV into this world. And we'll talk a little bit about that with special populations. Elizabeth Glazier died of AIDS. Yep, there we go. She is the woman, she was married to an actor, and she received a blood transfusion for a postpartum bleed. That was her exposure to HIV. She breastfed the baby, and the baby acquired HIV through breast milk, probably because she was seroconverting after she had the transfusion. She had a whole lot of virus in her body, and so the baby acquired HIV through breast milk. And that's how we found out that breastfeeding actually can transmit HIV if the mom has HIV. Going on now to 1995, AIDS is now the leading cause of death among all Americans, 25 to 44, more than cancer, more than accidents, because accidents really used to be the main cause. We now have AZT and other analogs, so we had a few new medications, but the first protease inhibitor. So this is really exciting because now we finally have a second class of medications that we can use to treat people with HIV, and it is a game changer. Because before that, when we talk about the HIV reproduction cycle, you'll see that all of the older medications we had only targeted one point in the virus's life cycle. So now we have possibilities for really controlling the virus by attacking it at two separate points in its life. A larger proportion of AIDS cases occur among African Americans than among whites. Inequalities in terms of access to care, perhaps fear of going to white medicine for many, many people because they were so badly treated. Why would you go to see a doctor when they're not going to listen to you, when they're going to disparage you and make fun of you and make you feel less than you are? We actually had a second class of medication, or a third class, released that year, and the combinations lead to a very dramatic drop in death. It was extraordinary because before 96 or so, 97, I was probably going to a funeral or a wake every week. And then all of a sudden I wasn't. And it was just amazing. People were living longer. And then we had the era of the AIDS cocktail. I'm sure you've heard the AIDS cocktail mentioned. And it was handfuls of pills. I mean, I don't know how people could actually take all these medications. They were with food, they were without food. They were with water, they were with extra water. You got kidney stones if you didn't drink enough water. It was just a crazy, crazy time. And that probably is not unrepresentative of what the handful of medications would have looked like. This gentleman here was an African. I can't remember the country, and I apologize for that. He died of AIDS. Unfortunately, he was a very popular performer and very influential with his government, but he was also an AIDS denier. And so that really did not help us to get information about prevention and treatment and accessibility and to reduce the stigma. AIDS deaths now have dropped by 1998 by about 21%, but now we're starting to see problems with lipodystrophy and side effects of the HIV medications. And I'm going to talk about that a little bit when we talk about the evolution of treatment. And needle exchange programs are effective because people who use heroin or other injection drugs, steroids, for example, those kinds of things. But unfortunately, nobody wants a needle exchange program in their backyard. So cities had to fight long and hard to get a needle exchange program. So in 1999, more than 95% of all HIV in the world live in the developing world, which has 95% of the AIDS deaths to date. And if you take a look at North America and Western Europe, we actually consume 95% of the resources that were available to treat HIV and AIDS. So developing countries really were not getting the support that they needed. Half of all cases occur to the under 25 group, larger proportion among African Americans than among whites. This should not surprise us. And women now account for 23% in the US as opposed to only 7% in 1985. So now women are becoming more aware and women are actually getting tested. Now Black and Latino men account for more AIDS cases among men who have sex with men than among whites. There may be religious or cultural issues that will preclude people who are gay and living in those populations from going forth, getting care and getting tested. There's discrimination and stigma everywhere. And then if trends remain unchanged, there will be more than 62 million people living with AIDS by 2005, and 40 million children will have been orphaned. And Kosi Johnson was a young boy from South Africa, and he was 12 years old when he died. He was identified as having congenital HIV. So he was kind of a test case in terms of getting your children tested if you were from a high-risk group. He became a very visible face of pediatric AIDS and did a lot of speaking and a lot of travel, but unfortunately, the medications just weren't there for him. So now we're moving on to 2002, leading cause of death worldwide among really adults who should be in the best health of their life. Taking a look at the cases of AIDS here, over 800,000 with 500,000 deaths by the end of 2002. But these are only AIDS statistics. These are not HIV statistics. In the beginning, we used to count numbers by dividing them. If you had AIDS, you were reported. If you had HIV, you were not reported. So really, this was tip of the iceberg. So for every person with AIDS, you probably had 10 people living with HIV who had not been identified or who had not progressed at that point to AIDS. This was really interesting in 2003. T20 or Fusion, that was the first injectable antiretroviral treatment that was licensed. It had a pretty short lifespan. It was an entry inhibitor, which was exciting because it could block the entry of HIV into the cell with some effectiveness. The problem was it was injected. And if you were giving yourself injections twice a day and you were in recovery from injection drug use, handling that needle might have been enough to trigger a relapse for you. It was just too triggering for people. The other thing is, apparently it hurt like a son of a gun. And you had to have a special aerosol dispenser put on the needle because it would rest in a bolus under your skin. It was quite painful. So you had to have something aerosolized so that it would sort of spread out into your tissues. So I had a couple of people on it, but they stopped. They said they couldn't handle it. It was just too painful, too much for them. 2004, we've got 15 million children who have lost parents. Growing AIDS cases in Eastern Europe and the former Soviet Union, because the Soviet bloc had fallen apart. And when that happened, of course, everything was controlled by Moscow. And when Moscow sort of stepped down or lost its power as being sort of the controlling agency, countries were scrambling. So all of these smaller countries that had been part of the Soviet bloc didn't know how to manage HIV. They didn't know how to get the medications. Their doctors were educated. They knew sort of what the pathophysiology was, but they had no access to it. And I was actually privileged to go to Ukraine in 2005 and with a group, and we traveled around the country talking about HIV and how do you start AIDS support organizations and how do you lobby for medications and these kinds of things. It was a real eye-opener for me. 2005, more than 1 million Americans are living with HIV. Nelson Mandela announces the death of his son from HIV as well. And Kaletra is approved as the first once-a-day treatment option. It's not one pill once a day, but it's part of the regimen where you could take it actually just once a day. So that was pretty exciting for us, for people who were taking medication like every 8 hours and setting alarms and everything else. African Americans, again, accounting for more than half of the new HIV cases in the States. But mother-to-child HIV transmission has dropped to less than 2% ever since we were able to prove that AZT given to the mom during pregnancy could substantially reduce the risk to the baby. So this was huge. The other thing is the first anti-HIV med that is taken once a day as a single pill. So this was fixed dose combination, 3 medications, 1 pill taken once a day. That was a real game changer for people. The problem with the tripla was that it had pretty bad neuropsychiatric side effects, so people could become delusional on it, paranoid on it. I used to tell people when they started to take it, if you've never dreamed in color before, you're going to dream in color because the effects were so profound. And also, interestingly, circumcision was found to reduce HIV infection in men by about 50%. And it's because there's immunologically receptive cells under the foreskin. You take away the foreskin, you've taken away a portal of entry. Let me see, 2007, 33 million people living with HIV. The MSM initiative, Men Who Have Sex with Men initiative, it's a global program to support HIV prevention and treatment, because this was the group really that where HIV was first sort of identified, and they became very stigmatized and they became very activist because of that. And we have a new entry inhibitor, Maraviroc. There are 2 possible entry ports on the cell. We're going to talk about that in a little while, but it blocks this one particular entry port, and, and it can be very effective. Revised estimates, about 56,000 new HIV infections, but we also have the Berlin patient who had a stem cell transplant. And his donor for the stem cell transplant happened to have that CCR5 blocking mutation. So guess what? He had a stem cell transplant. Of course, his whole immune system was wiped out, but he cleared the HIV. And he can't get it again. So this is the good news. So this is really important when it comes to looking at how we can prevent HIV infection. Stem cell transplants are, they're a wonderful thing and they can save your life, but they have to work. And so once we've destroyed your whole capability of producing blood for your body, you better hope that it works. So I know when this first came out, everybody wanted a stem cell transplant, and we had to say, no, it doesn't quite work like that. What else? We've ended our travel ban in 2009. Now we are looking at vaginal microbicides applied before heterosexual contact to reduce HIV transmission in women. So this is very exciting. This is the pre-exposure prophylaxis or PrEP that you may have seen on TV. We're going to talk about that in a bit. Taking medication could significantly reduce infection among men who have sex with men. Putting healthy people living with HIV on antiretrovirals limits transmission of the virus. And we're going to be talking about the partner study in a bit, because that is really important and a total game changer in terms of sexual activity. And now we're still looking at 1.1 million people living with HIV in the United States, but living with HIV in the United States, because now we are managing this as a chronic health condition. And I tell people, this is not a death sentence, this is a life sentence. I hate to put it like that, but you can be healthy in the presence of chronic illness. We need to change our construct of health, because health is not the absence of illness. Health is your ability to live to your fulfillment, to be happy with the way that you're living, to do things that you want to do, to have pleasure in your life, those kinds of things, to have meaning in your life. So we have to redefine now health in the context of HIV infection and how it is now a chronic health condition. We have now approved Truvada for pre-exposure prophylaxis. This was a huge chunk of what I was doing. The Mississippi child who showed no traces of HIV after stopping antiretroviral medication. This was a child who was congenitally exposed, started HIV treatment right away, and then they stopped the medication, but the virus rebounded, so it wasn't a cure, unfortunately. And then 2 HIV positive patients had bone marrow transplants for blood cancers, were apparently virus-free, but they stopped antiretroviral medications and they rebounded, the virus rebounded. So there was no cure there. This was Timothy Brown, the Berlin patient. This was the first phase of the partner trial where they looked at people, the serodiscordant couples, where one person has HIV, one person does not have HIV, and they looked for transmission rates among that population. I'm going to talk about that when I talk about PrEP. The WHO recommends daily oral PrEP, so the Truvada, as an additional prevention choice. And then the ban was lifted on blood donations by men who have sex with men if you were abstinent for a year. Good luck with that. And then in 2016, undetectable is untransmittable. So in other words, if your virus level is really low, it's really difficult for you to pass it on to somebody else. So that was a huge finding. Unfortunately, the PrEP has its pitfalls. A man who was taking Truvada, and they know because they checked his prescription pickups, they did blood levels for Truvada, but he still contracted HIV on it, so it is not foolproof. I tell people this. I mean, they say, well, I can do whatever I want. You're going to do whatever you want, but I need to tell you that there is still a possibility. This I found very discouraging. A meeting on ending AIDS. The UN member states pledged to end AIDS, but controversy after more than 50 nations blocked participation of groups representing the LGBTQ groups from attending. So, the bias has just shifted its focus. And then again, African American men have a higher rate of HIV prevalence. PrEP is associated with a 25% reduction in new diagnoses in 1 year. And I know that all of the people that I was seeing for PrEP, men and women, I probably would have been seeing them as patients living with HIV if they hadn't been taking PrEP. In terms of the downside, living with HIV twice as likely as their HIV negative counterpart to suffer from heart disease. Some of that may be related to medication side effect. Some of it, we're going to talk a little bit about HIV in aging populations, and you'll see that what happens as people get older. The London patient may be the second to have been cured of HIV. And then the plan for America to reduce the number of new HIV infections by 75% in 5 years and 90% in 2030. So we were about 12% lower 4 years ago. The death rate is dropping substantially. An Argentinian woman appears to be spontaneously cured. I'd love to have read the whole paper on that. I could only find just the excerpt. Botswana becomes the first high-burden country, so in other words, a very high HIV-related population, to significantly reduce mother-to-child transmission. And then 2 long-acting injectable antiretrovirals are approved by the FDA, so 2 more injections. More individuals appear to have been cleared with stem cell transplants, both from donors who had that CCR5 mutation. And then there is a group, the exceptional elite controllers. They're very few, but these are people who have HIV. They test positive for HIV, but their HIV, despite never taking treatment, never seems to progress. Their immune system remains intact. All of their other sort of biological markers remain intact. So, you best believe they're donating buckets of blood so that we can study and try and figure out what is so very special about them. Oh, now, guess what? MSMs may donate after only 3 months of abstinence, so maybe people want to be a little bit more open to people who are in either mutually monogamous relationships, consistently test negative, whatever. Tennessee rejects the use of available federal funds for HIV prevention, and when we look at the statistics and where HIV is in this country, this will make sense to you when you take a look at the prevalence. Uganda's Anti-Homosexuality Act. There's a Geneva patient who may have been cured, and new post-treatment control of HIV. This man has remained undetectable for close to 2 decades post-treatment. So that's, again, pretty incredible. And again, studying him to see what is very special about his blood. Lenacapavir, this is kind of the newest kid on the block, found to be 100% effective when preventing HIV infection. I'm going to talk about that in a bit. There's a second Berlin patient, and now if you are living with HIV, you cannot be denied the opportunity to serve in the American military. So I want to take just a quick look at the natural history of HIV, just as a quick refresher here. It will explain, I think, a lot of sort of the history of why people felt what they did about HIV, and just helps us to take a look at where we're going. So, as with anything, you have to start with risk. So, they can be sexual, shared drug work, non-injection drug users itself. If you've got your own works and you're clean, that's really not a risk for HIV, or a risk for all kinds of other things, but not for HIV or hepatitis B or C. So shared works, occupational risk, which of course is very important to all of us, and perinatal. The exposure can be sexual, parenteral, which is needle sticks or splashes onto non-intact skin, or a mucous membrane type exposure. The window is the time between which the virus enters your body and you actually test positive for HIV. We used to have to wait a good 6 weeks to know if somebody was living with HIV or not. Now this 4th generation antigen antibody test that we have detects this P24 antigen before antibody formation. So if you take a look at this right here, so here you have the point of infection over here on the left. Here's your CD4, your immune system. It dips briefly when people are first living with HIV. You have this P24 antigen, though, that rises very quickly, about 3 to 4 weeks after exposure to HIV. So if we were to do a 4th generation HIV test in this time frame, we would be able to diagnose it because this P24 antigen would tell us. The older HIV test over here, was an antibody test. And you can see it takes a good 6 weeks or whatever to actually come back positive. So there were 2 tests. One was called an ELISA, which was I call it a buckshot test. It looked for any antibody in your body. And if that was positive, then we would do something called a Western blot. And the Western blot was a more expensive test, so of course they used the ELISA as a screening test. But by the time we got all of this information back, it was probably a good 6 to 8 weeks after. And that's a long time if you've had an exposure to know whether or not you've acquired HIV or not. But with this newer test, we can pick it up much, much more quickly. Within about 2 weeks. So it's pretty impressive. So when people are first exposed, they have what is called a seroconversion illness. And most people will write it off. I had the flu, I was just down a bit, maybe I was drug sick. People's capacity for denial is extraordinary. And it's flu-like illnesses, so anything you might think of, lymphadenopathy, sweats, muscle pain, joint pain, those kinds of things. So at that point, your CD count is about roughly within the normal range, and your CD4 is a measure of your immune system. If you take an average of, say, 1,000, which is where it would be in most labs, it's always a range, but say 1,000. For every year you have HIV and you don't take treatment, your CD4 will decrease by between 80 and 100. So early HIV infection, CD4 between 1,000 and 500, because it's dropping all the time. It was called asymptomatic HIV infection, and you could probably be in this range for about 5 to 8 years, depending on how much virus you had. There were variables. Symptomatic HIV infection, when your CD count got below 500, because that's when people started to have trouble with chronic infections, with diarrhea, with seborrhea, things like that. And it was called AIDS-related complex because nobody knew what else to call it. So this is what the rash of seroconversion might look like. If you've ever seen measles, you're probably not even old enough to remember measles, but it's a macular-papular rash, so if you run your finger along the skin, you can kind of feel the bumpies. Also oral candidiasis. The problem is many people who will use a steroid-based inhaler will get oral candidiasis if they don't rinse their mouth out. Lymphadenopathy, so especially around in the neck chains. You can see this gentleman here has got pretty substantial lymphadenopathy right there. Swollen lymph nodes in themselves, if you've got a bad sore throat, if you've got strep throat, swollen lymph nodes are not a bad thing because they simply say your immune system is fighting. But in the absence of other causes, they are worrisome. And I did have a gentleman whose nodes, his earlobes were absolutely flipped right up, they were so big. And then late HIV is where you meet the CDC's criteria for AIDS. So your CD4 is less than 200 or 14%. And it's because all of these opportunistic infections, they're all many organisms that most of us will have in our bodies, but they take advantage of the opportunity that a weakened immune system has given them. So we would also see some of these, for example, in people who have had organ transplants because they're taking immunosuppressive therapy. So this chart here shows when is an opportunistic infection likely to show up. So here you have your little CD4 dip at the beginning, and then it's slowly decreasing over time. After about 5 or 6 years, maybe a risk for shingles or vaginal candidiasis. After about 7 years, now you're looking at Kaposi sarcoma. If you test positive for tuberculosis and you've never been treated, it's possible that could reactivate. Now we're looking at the major opportunistic infections, the pneumocystis pneumonia, the fungal infections, and then down in here, more of the viral and bacterial ones. So the longer you go without treatment, the greater is the possibility that you're going to run into one of these kinds of infections, that the organism will reactivate. There's also the constitutional things, the night sweats. Drenching night sweats where you take off your pajamas and they splat on the floor and you strip your sheet and you flip your mattress, and just drenching night sweats. Fatigue, anemia, muscle wasting. If you look at this poor person, they have no gluteals left. Their deltoids are gone. They have no muscle. The AIDS is basically consuming their body. There is the malar wasting over here, and then the temporal wasting as well. The muscles are disappearing. So the lab work that we're using, we use the HIV serology, which is the 4th generation test, and we use that to determine status. Does this person have HIV or do they not have HIV? It's an either or proposition. And it's voluntary by state. So in Massachusetts, we must have permission, but we're able to do it with oral permission. And we're trying to use what's called the opt-out approach. So an opt-in approach would be, I think everybody should be tested for HIV. Do you want to be tested? An opt-out approach is, I think everybody should be tested for HIV. So unless you have an objection, I'm going to test you for HIV. So it's almost like you've handed over the decision making. People can say no, and we have to respect that decision. But we do encourage people to get tested. The CD4, or T cell count, or T4, they're all the same, is used to assess immune status. And we also use it to see, do we need to start prophylaxis for opportunistic infection? If you come in and your CD4 is 100, I'm going to want to offer you some Bactrim to prevent you from getting pneumocystis pneumonia until I can get your immune system back up into the normal range. Those kinds of things. Viral load, sometimes it's called a PCR or a NAT, nucleic acid testing, things like that. Viral load is probably the most commonly used term. And this tells us how many copies of the virus there are, how much viral RNA is in 1 milliliter of blood. And it ranges from undetectable, depending on the lab. UMass's lab is less than 20 copies to less than 400 copies, or if you're not on treatment, it can be in the millions, especially if you're just seroconverting. And then we also use it to check the antiretroviral to see if it's working. If you come in with a viral load of 100,000 and I give you medication, I expect if you're taking the medication and the medication is the right one for you when it's working, I should be able to get an undetectable viral load. So these are like the surrogate markers that I was talking about earlier. And then genotyping is done when I can't get an undetectable viral load on people. I don't know what's going on. They're taking their meds. So I will check to see if the virus has mutated in such a way that those medications won't work. So the CD4 indicates intactness of the immune system, and then the viral load, how many copies of the virus, and it's about medication effectiveness. When people first become HIV positive, they get what is called a viral set point. The virus rockets up very high at seroconversion, and then it sort of levels out over time to a set point. If you're lucky, your viral set point will be low, maybe under 500, which means that there'll be a long time before your immune system becomes damaged. If you're not lucky, your set point can be 100,000, which means that you're going to get sicker faster. And it just makes intuitive sense. The more virus, the faster is the possibility you're going to get sick. I took care of a man who came into care in 1996. His CD4 was 4, count them 4, right? His viral load was 500. And he had a huge Kaposi sarcoma growing out of the sole of his foot. It looked like a purple cauliflower. So we put him on medication. Within 6 months, his viral load was undetectable. His CD4 was now 8. In a year, it was 12. His immune system had been so damaged for so long, it took years to get it above 200. But he didn't feel sick. The Kaposis went away because his virus was under control. So the thing is that the higher the virus, when people come in, the chances are better that we can get a faster immune response because the immune system has not been damaged for that long. But it's the people who come in with a really low viral set point and a really low CD4 that can take years to actually recover their CD4 because the immune system has been damaged for so long. So this is another sort of model that shows over here. So this is the CD4 at primary infection, and you can see it drops down briefly, comes back up, but then it deteriorates over time. And then over here you have the viral load rocketing up and then a set point over here. And then towards the end of life it would shoot up again. So why can't we have these great medications. We can get the virus to be undetectable. We know that these things work. The problem that we have is called latency. So the virus lives in these latent, inactive memory, T memory cells, and they exist all over the body. The virus really only reacts to the medication when it is rapidly reproducing itself. So if the virus is latent, the medications, it just ignores the medications. They just wash right over it, and there's the latent virus just snoring away, waiting for an opportunity to wake up, waiting for the medication to stop and become active again. So everybody has these reservoirs of latent virus in their body, and the medications just don't touch it, not unless the virus reactivates, and the virus will reactivate if you stop taking the medication. So now we're stuck all over again with treating an active infection. All right, so now we're going to talk about treatment. So this is my gentleman who died back in 1997, and he was the original bad luck guy. He was diagnosed in 93. His opportunistic infections included pneumocystis pneumonia. He had cytomegalovirus retinitis, so he was going to go blind if he did not take medications. He had candida esophagitis, so every time he tried to swallow, it stuck all the way down. Bad luck, HIV-related cardiomyopathy. I think I've only seen 2 other people in like 33 years with HIV-related cardiomyopathy, and terrible peripheral neuropathy. He could barely stand, pins and needles and so on. He was a piece of work though. On the one hand, he came in, he wanted a candy apple red motorized scooter so he could get around. I said, we'll do an application. I don't know if you get candy apple red, but you get it. And he wanted a seeing eye dog because he couldn't see that well. I said, do you not see the contradiction here? You're asking me for a motorized vehicle and a seeing eye dog. I said, I said, let's go for the scooter, okay? I think we can do this. This was his medication list. 2 Combivir, which was AZT, and something called Epivir. 6 Crixivan, so this was his HIV regimen. And the Crixivan had to be taken with an additional 64 ounces of water or you would get kidney stones. Bactrim, double strength, to prevent the pneumocystis pneumonia. Ganciclovir, to prevent the CMV retinitis from progressing, but the ganciclovir kills your bone marrow, so he was on GCSF, Neupogen, and Epogen, 6 injections per week. He was on fluconazole, a couple of fluconazole a day for his candida esophagitis. For the myopathy, he was on digoxin and Lasix, and for the peripheral neuropathy, he was on morphine extended release and morphine immediate release. So 40 pills a day and 6 subcutaneous injections per week. So taking a look at how treatment has evolved then. So 1987, this was a banner year. We actually got a medication approved, AZT. 93, we had 2 medications here, DDI, Videx, and then something called HIVID. What an unfortunate name to give a medication when HIV was so stigmatized at the time. So 95, you can see we're getting more medications coming out, and then this is where the protease inhibitors, that class of meds, came out. It was called HART, Highly Active Antiretroviral Treatment, or the AIDS cocktail. And then we changed it, and then we called it CART, which was Combined Antiretroviral Treatment. It's like a moving target. And then we got injectables. And so now what we're looking to in the future is things like transdermal or implanted systems. They did look at patches, but the absorption rate was inconsistent. It was very difficult to assure a consistent dose of medication. And maybe vaccines, and maybe biologic intervention. So, there's a lot going on right there. So this is just a list, and you have it in your packet. You can see the different years that different medications came out, and this was where there was this explosion of new medications, and we were like kids in a candy store. We were just like, oh, this is great. You can try this one, you can try this one, and just all the combinations and permutations, and then it came back to bite us on the butt, which we will talk about. And then over here, this is where you have a lot of these fixed dose combinations. And what those are is a combination of medications, 2 or 3, where you can take 1 pill once a day, which is a real game changer for so many people. And then we have the injectables. In 2021, Cabenuva, which is given every 8 weeks, and then lenacapavir, which we'll talk about, a capsid inhibitor. So, we have a lot of medications at our disposal now. And many of these older ones here, I don't even think they make them anymore. I certainly haven't prescribed them in years. So where do the meds work? So this is the HIV reproductive life cycle. Over here, you have a binding area. This is the virus coming along to attack your CD4 cell right there. So you have that famous CCR5 entry point right there, but there's another one called CCXR4. If you have only CCR5, then that medication Maraviroc will work for you. But if you have both entry points, it won't work. So we do this genetic testing on everybody so we can see if we need to go to using the Maraviroc, will it work? There are also, this is where Fusion, that medication that was twice a day and hurt to give, this is where that one was effective. And then the reverse transcriptase, because as the virus injects itself into the body, it attaches and then it injects its genetic material right here. It is RNA. It cannot really do any damage with an RNA-based virus. However, it contains reverse transcriptase, and reverse transcriptase transforms that one strand of viral RNA into 2 strands of DNA. So now it can inflict some damage. Now it is compatible with us. Then there is integrase, and it integrates itself into the nucleus where it combines with your own genetic material. So as I said before, if every single person in this room had HIV, it would look different in every single person because you produce virus that is sprung from your own DNA. So any vaccines that we had thought about using, we can't use that vaccine model anymore because you would have to have a vaccine that was mutable per person. It would have to change with every single person. Interestingly, hepatitis C is also a retrovirus. So it has reverse transcriptase, but it does not have integrase. So it reproduces in the cytoplasm, and then when hepatitis C leaves your cell, it looks exactly the same as it did when it came in. So that's why we can cure hepatitis C, because we can attack the virus basically from what it looks like, the original virus. But we can't do that with HIV. So now the virus has mixed it up with your own DNA, and now it starts to produce copies of the RNA that carry your genetic imprint on it. So there are translation and transcription. We do not have any medications to affect those yet. And then over here, protease that packages up the enzyme or the virus to go off and then infect other cells. So you can see this is where the medications work. They work for binding, they work for reverse transcriptase, and then there's another one that interferes with the capsule formation. We have ones that interfere with integrase, and then we have ones that interfere with protease. So we can attack the virus at different points in its reproductive cycle. The older medications that we had, the AZTs and what else, the Epivirs, things like that, they only worked here. They only worked in a single way. So we have a different class of medication that actually works in the same point, and if you combine those, then you can actually use medications to target this one area, but you have to use kind of like the cousins to attack it. The other issue that we have, and I've mentioned this, is with resistance. So people have wild-type virus. If you have wild-type virus, anything you throw at it will work. But most people, because you're getting virus from other people and other people have been exposed to different medications, you may be getting resistance to different kinds of medication. So if you have drug number 1, it may just wipe out, it may wipe out like the wild plus 2 and 3 or whatever. But you need a combination of medications to wipe out all of these combinations, because almost everybody will have a resistance mutation at somewhere in their body just because of the way the virus is spread and because of the way the virus mutates in the original host. So when do we start HIV? Well, in 1987, when all we had was AZT and we really didn't have viral load markers, we couldn't really tell, how much activity was going on. We used to wait till the CD4 hit 500 because that's when people started to have that AIDS-related complex with the night sweats and the weight loss and things like that. Then in the mid-90s, when we got all of that huge amount of medication, hit hard and hit early. Then we backed off for reasons that I'll come to in a second. Then in around 2000, we were looking at the CD4 maybe 200 to 350, which is a heck of a lot lower than this, or if people were symptomatic. So why did we back off? Because there were all these side effects that we did not see because of the work by the ACT UP Coalition to fast track a lot of medications through the FDA. They were assessed for safety, so we knew that they wouldn't kill you outright if you took them, and we knew that they were effective because of the work that we had done to make sure they were effective, but we didn't know long-term side effects, and that tends to be the bigger issue with just about any medication, because you can study it for so many years, but until it's been in the population for a good 5-10 years, that's when you start to see long-term issues, if there are going to be any. So they're metabolic and morphologic problems. So the metabolic side effects, impaired glucose metabolism. So we were seeing people who were just maybe pre-diabetic getting pushed into diabetes. We had a lot of difficulty controlling glucose metabolism. Dyslipidemia, people's triglycerides started rocketing up into the 3000s. Bone disease, osteonecrosis. We used to see a lot of osteonecrosis of the femoral head and of the humeral head. So that was pretty much related to the older medications. And then morphologic changes. There was a shift in the way fat was distributed in the body. It would, people would have lipoatrophy. They would lose the fat, not the muscle like we saw initially, like when the person had terrible wasting and had lost their muscle, but it's fat loss, and it would shift from the extremities, from the buttock, from the face, and it would all end up in this central adiposity, which was quite disfiguring. And you can see here, there's this buffalo hump right there, which is sort of a typical, that dorsal fat pad. And the problem here is that liposuction won't work because it's very fibrous. You sort of have to go in with an incision, scoop it all out, and then it can recur. Some of the central adiposity, same belly, a couple of months later, and you can see that there's been fat redistribution, and there's also breast enlargement. This is a woman who has taken the medications. You can see that she's got no fat on her legs. She's very muscular, yes. It's not like HIV-related wasting, but you can see that the fat has left her arms, her legs. You can see that it's been sort of redistributed in the breasts and sort of in the central area of her body. I remember one of my very nice patients coming in one day, and she said, she was so upset. She says, my boobs are growing and my butt is shrinking. I said, oh. She was a lovely Puerto Rican lady, and she says, I want my butt back. I'm thinking, I'm an Anglo. We're not about the butt. And then there's malar wasting. You can see this person here has lost a lot of the weight around her cheeks. And then peripheral wasting. You could almost do an anatomy lesson on the venous architecture of that leg. So the moving target, when do we start? So now let's fast forward to 2008. So we're still at 350 to 500, or if people are symptomatic with those constitutional symptoms, or if the viral set point is high. So if you come in with a viral set point of 100,000, we really do want to start earlier than maybe if you come in and it's, say, 500. Or if the CD4 seems to be dropping in a hurry. Then we changed it again. If women were pregnant, yes, absolutely we want to get them on. HIV-related nephropathy. We're starting to recognize now the effect of HIV on kidney health. And if you have hepatitis B, because some of the same medications that we can use to treat HIV also treat hepatitis B. So you're getting a twofer if you happen to have hepatitis B. And then there were two studies that were done, START and Temprano. And they looked at people who started antiretroviral medications at an earlier stage in their HIV illness. And they found that there was much lower morbidity and mortality if they started their CD4 they started their medication at a CD4 of greater than 500. So in other words, earlier is better. And with the medications we have now, we're not really seeing yet those horrible side effects. So currently, it's recommended for everybody as soon as possible. And sometimes, people need a chance to sort of think about things, to settle into their HIV infection, to think about the changes that might mean for them, to organize themselves. But there are some instances where we do want to push a little bit harder. And I'm a great believer in, self-determination and self-destination, that sort of thing. People have a right to make decisions about their body, but there's times when I'm going to say, time is of the essence here, and we really don't want to wait too long. So, if it's early or acute infection, lower CD4, disease advancement, nephropathy, pregnancy, chronic Hep B or Hep C as well, because we want to get treated for Hep C, but we also want to be sure that your immune system is healthy enough before we start doing that. But we have options, and it's lovely. One pill once a day. We have all of these options that we can offer people. Different side effects, maybe different medications that they may be taking. We're sort of juggling polypharmacy. And then there are the injections. Cabenuva, cabotegravir, you may have seen it advertised on TV. They're really kind of pushing it now. 2 injections 2 injections 4 weeks apart, and then 2 injections every 8 weeks. So you can come in, we'll give you the injections, and then you can go on your merry way. The HIV will be well controlled. We want an undetectable viral load before starting. So if you come in and you're not taking any medications, we're probably going to want to start you on one of these, make sure that we can get an undetectable viral load, and then we're going to start you on the Cabenuva if that's what you would like to do. But it really does make people's lives a lot easier. Some people are very pill averse. And I had one person tell me, every time I take a pill, it's shoving my diagnosis down my throat. I said, well, we can do the injection. And they're much happier. It's a very individual thing. Some people who are doing very well in terms of managing their HIV, I may only need to see them every 6 months. They'll say, I'm fine with the pill. I don't want to come and see you more often than twice a year. Fine, it's up to you. But there are individuals with archive resistance in multiple drug classes, long-term survivors with decades of HIV experience who have taken multiple meds. This is where altruism can sometimes come back and hurt you. For people who participated in the early medication trials, because they were giving one medication at a time, one new medication, because we didn't have other things to give, because we didn't know what the long-term effects were going to be, they may have developed resistance mutation to some of the older classes of medication, and sometimes there's cross-resistance with newer medications. So that's the problem. Some people are on very complex regimens as well, and just making sure that we can actually get control of the virus on these simplified regimens. Polypharmacy and comorbidities, depending on what other medications you need. Do you need an anticoagulant? There may be issues with that. Do you need anti-hyperlipidemics? There may be issues with that. So we really have to, we're constantly juggling medication side effects. And then there is the twice yearly injection. Lenacapavir, which is the new guy. Yeztugo, I don't know who made these names up. It's licensed as monotherapy for PrEP, for pre-exposure prophylaxis, but not for HIV treatment. We're going to talk more about PrEP in a bit. And it needs to be taken in combination with another medication to treat HIV. So we're studying rilpivirine, which is the same medication that we give with the cabotegravir every 8 weeks, but that means every 8-week injections. And then they're also looking at oral Biktarvy plus the lenacapavir twice yearly, but you're still taking a medication every day. So there are risks and benefits. There's lifestyle choices that people need to make. And what this basically means, they did a 48-week study, people who were on complicated regimens for HIV because they had difficulty controlling it, and people who took the twice yearly lenacapavir with the Biktarvy every day, non-inferior. What does that mean? That simply means that one wasn't better than the other. That's all. That's research talk. In terms of getting people onto treatment, this is like the Titanic iceberg. We want people on treatment. We want to make sure we get them on in a timely way. But we have to deal with everything that is going on in their life in the meantime. If people are hungry, if they have nowhere to stay, if they're out turning tricks to get drugs, or because they're afraid someone's going to beat the crap out of them if they don't. We have to deal with these things. We have to meet people where they are. Substance abuse, mental health issues. We have to deal with all of the health maintenance things, all the screening labs. Because all of this whole infrastructure here will help the antiretroviral medication to work better, and will give them the life that we hope that they would have. And to be honest, the medications are great and they work, and they are necessary and essential for what people need to do to survive HIV. But the other thing is, people's success in managing HIV or any other chronic condition is really predicated on the relationship that they have with their healthcare team. With the nurses, with the medical providers, with their dietitians, whoever. Just helping people to feel partnership and to feel supported and cared about and respected. That really is what this slide is about. So I want to talk about special populations now. This boat has unfortunately sailed. No child born with HIV by 2015. No, not quite, but we're getting close. So this was an effort to reduce maternal to child transmission. So the WHO validated These developing countries, Cuba, Thailand, Belarus, and Armenia, they received validation because their rate of maternal-to-child transmission of HIV was less than 1%. I mean, these countries have done an extraordinary job of educating women and getting people into treatment. It's early access to care, it's testing, supportive measures. We are at a 1.3% transmission rate, which is higher in the African American group than it is in the white group, which statistically is borne out by every other statistic we've seen this evening. So we talk about vertical transmission, maternal to child transmission, from the mom to the baby. Horizontal transmission is from one partner to another. And then we talk about seroconcordant and serodiscordant couples. Seroconcordant, both infected or both non-infected. Discordant, where one is infected. And they're also called magnet couples because one is positive and one is negative. So if you think of nearly 80% of women living with HIV are of childbearing age, it's really important to get education and support out. In 2023, 1.2 million pregnant women living with HIV. And in US, women ages 25 to 35, 35 to 44 account for the highest shares of new HIV infection. So in terms of pregnancy, the risk is during the pregnancy, the labor and delivery, and with breastfeeding. Without intervention, the risk of transmission from mom to baby is somewhere between 15 and 45%, which I find astonishing. I guess I thought it would have been higher. With undetectable virus, less than 1%. So there's every reason for women to feel hopeful. So the key factors here, viral load. We'd like the mom to have an undetectable viral load. If the membranes are ruptured for more than 4 hours, that increases the risk to the baby. Invasive procedures, fetal scalp monitoring, episiotomy, all of those things that interrupt fetal skin integrity and increase the exposure to maternal blood will increase the risk of HIV infection. And then if the mom has another STD or a low CD4. In '85, the CDC encouraged HIV-positive women to defer pregnancy as long as they could. 2001, they decided that women living with HIV should receive all possible information and support about reproductive options. And then the following year, the American College of Obstetrics and Gynecologists, they promoted assisted reproductive techniques to be offered to all couples, regardless of HIV status. So we have really changed a lot because we know we can do a lot more to support people to move forward with their lives. And you can see here, this was the rate, this was the high point of maternal to child transmission right here before we started to get AZT licensed in 1994, right about there. And over here, I mean, we didn't know about HIV in 1977, so what's that all about? That is because children who were sick and hadn't been picked up at birth as being sick, but maybe now they were school-aged children, and we started to look into what's going on. Why are children having these strange opportunistic infections? And then they realized they probably had been exposed at birth. So now it's like 1987, and now we're testing them when they're 10 years old, and we're realizing that they had HIV. So this is Pediatric AIDS Clinical Trial Group. They determined in '95 that AZT would reduce the result of, would reduce in by 67% perinatal transmission. And then there was a 3-part regimen. So the mom would get AZT during her pregnancy, she would get IV AZT during labor and delivery, and the baby would get AZT after birth. And they also started to really push for universal, the opt-out testing. We'd like to test you unless you have an objection. And then there were multiple trials in developing countries with different medications, nevirapine that was given to the laboring mom and baby for the first couple of weeks of life, and then something called the PROMISE, which was a 3-drug regimen given to the mom and the baby, and it did show a substantial drop in maternal to child transmission. There's preconception counseling if people come in and they're thinking about pregnancy, but of course most pregnancies are not planned. 50%. So we want to ascertain your status, test the partner, talk about how HIV affects pregnancy, avoidance of breastfeeding. I'm going to talk about that in a minute. And then protect the immune status. Get the mom on antiretroviral meds. So why doesn't every baby born to a parent, male or female, with HIV have HIV? And that's because HIV is carried in the seminal and follicular fluids, but not in the gametes, not in the ovum, not in the sperm. They're only carried in the fluids surrounding those cells. We don't really understand how HIV swaps back and forth between blood and seminal fluid and blood and follicular fluid, but they're not in the gametes themselves. So what happens to a pregnant woman living with HIV? So viral load should be unaffected, but it depends on if she's able to continue taking the antiretroviral medication. The CD4 dips a little bit, and it's just hemodilution of pregnancy. By the third trimester, a woman can be carrying an extra 1.5 liters of fluid, so it just makes sense that there'd be a little bit of hemodilution. The AZT may cause bone marrow suppression, although we're not seeing that much more. And then morning sickness may make medication adherence difficult. So what are we doing? What else are we doing? Antiretroviral medications, preventing opportunistic infections, avoiding invasive procedures. Superinfection means that you have control of your virus, but somehow you have been exposed to another strain of the virus. Maybe you've shared a needle, maybe you've had unprotected sex with somebody, but you can get a superinfection, which means that your new virus may be resistant to the medications that you're currently taking, which means we would have to scramble and find new regimen for you. Cesarean section at 38 weeks if the viral load is more than 1,000, or if there's STDs. And we don't know how effective it is if there's prolonged rupture of membrane or if she presents in active labor. We will use IV AZT if the viral load is high or we don't know what it is. And supposing it's a woman who shows up in active labor, no history of prenatal care, somebody coming in from a developing country, we may want to consider a cesarean section at that point. We will try to get an expedited HIV test, a 4th generation test, or a rapid HIV test at that point. And in terms of breastfeeding, if the viral load has been suppressed, there's low risk of HIV transmission. The baby will get zidovudine for 2 weeks. If there's a high risk, then the baby would have to be on a more extensive protocol after birth. And if there's a lower risk, then a sort of a shorter protocol. But there are definite protocols that we follow in terms of treating the baby in terms of post-exposure prophylaxis. So breastfeeding, viral suppression during pregnancy and postpartum decrease the risk to about 1%, but it's not 0. And there's really no consensus. That's sort of the problem. If the mom develops viremia, we'll have her stop breastfeeding and give the baby post-exposure prophylaxis. We don't know if breastfeeding can be resumed. In general, they found that in developing countries, the most harmful thing you could do would be to switch from breastfeeding to bottle feeding to back again, because it's just too hard on the little gut to tolerate all those changes in the milk that it's receiving. So babies actually did better if you could just treat the mom and keep them on breastfeeding. In this country, we have options. If women want to continue taking the medication, they can certainly do that. They can try breastfeeding. It's the opinion du jour, basically. So basically what we want is universal testing and counseling. We want to have maternal treatment during pregnancy, elective C-section if there's detectable virus, and then avoid breastfeeding, and that can reduce the risk by about 1%. In terms of HIV in older adults, that's the other sort of special population, more than half of the people in this country living with HIV are over 50. It wasn't a consideration back in the early days because most people died within 2 years of their diagnosis. And in fact, even with the older antiretroviral medications, they had to be taken with high-fat meals. So, we weren't even thinking about cardiovascular health at that point. We were just wanting to get control of the virus. And we say, here's your pills, get a pint of Haagen-Dazs, make yourself happy. And now we know all the cardiovascular issues. About 54% are over 50, and this is newly diagnosed and long-term survivors. So, of the 55, over 55 who received a diagnosis, they were already in late-stage HIV because they probably weren't getting tested. Healthcare providers don't always test people for HIV. They may miss the signs. They may be uncomfortable having a conversation about sex with people. and we have to give permission for people to disclose these things because there may be shame and stigma and things like that. We have to say, listen, you've been alone for a long time. In terms of your sex life, many people, I've given permission there, I've said, you're not the only one, many people will go out and find another partner. They'll do a hookup. Maybe they'll pay. Is that working? Is that how it's working for you? Because I've sort of put it out there that I understand what the options are, and I'm not afraid to talk about it. So why don't we talk about what's best for you? Symptom overlap in terms of HIV and aging. If you take a look at the frailty phenotype, where people they become less active, less able to sort of advocate for themselves, less social, a little more cognitive decline, all of those can be symptomatic of advancing HIV as well as aging. So people have to be a little bit more aware of what else is going on in somebody's life. And it's really hard when you have 15 minutes to spend with a patient and they've got 30 medical problems that you have to address. So what causes the overlap anyway? So chronic inflammation accelerates the aging process. And we know that even with controlled HIV, there is a level of just chronic inflammation that is going on, which is aging the population, is aging cognitive function, is aging your cardiovascular health as you go on. But even with exquisite control, there is this low level, sort of more rapid aging. Immune senescence. So everybody, as we get older, guess what? Our immune system gets older too, and we have this immune senescence. So it increases our vulnerability to cancer and infection anyway. That's why we tend to see more cancers and more infections in older people, because we are less likely to fight that off. We have to look at the comorbidities. As you get older, the older you get, more cardiovascular disease, more metabolic disease, more neoplastic types of diseases. And these can all be advanced faster if your immune system is not as strong as it was. Antiretroviral side effects. Now, mitochondrial toxicity. We used to see a lot more of that with the older antiretroviral medications. The AZT was sort of infamous for that. But we don't see as much of it anymore, but that doesn't mean we should not be alert to weakness, to respiratory difficulties, things like that. And then lifestyle factors as well. Sedentary lifestyle factor, social isolation. Probably the most important thing that an aging person can do is remain socially connected. The more connected you are, the more you're out, with the public, with interacting, learning things, trying new things out, the greater is the possibility that you will age successfully. And then we have to deal with the smoking, the nutrition, poor nutrition. I mean, can people afford to eat these days? A bag of groceries, it's ridiculous. It's cheaper to go to McDonald's and buy a burger than it is to buy, a small chicken and a bag of apples, which would give you a healthier dinner. Other things, stigma negatively affects people's quality of life and their self-image. People don't want to think that they're going to be affected by HIV. There is a certain kind of belief in the myth of your own immortality. It's never going to happen to me. It's all of these things. And as you go on, you realize that these things probably are going to happen to you. It may prevent them from disclosing their HIV status, or it may prevent them from disclosing that they are at risk for acquiring HIV. In my prep work, and I did a lot of prep work, there were so many people who would come in their 60s, and people who were no longer in long-term relationships, or people who finally had come to terms with their sexual identity as to who they really are and wanted to live their authentic lives and wanting to know how they could best protect themselves. So I just think that it's validating people to be who they are and to welcome them and to have these conversations with them is critical for their survival. Polypharmacy is a huge problem. I mean, people come in. I remember one woman coming in and she had like 26 medications in a bag, and I said, are you really taking all of these? They were duplicates. There were medications that had expired 2 years before, and just sort of sitting down and going through all these medications and trying to figure out drug-drug interactions. And as much as the electronic medical record makes me crazy sometimes, it's really helpful to be able to send a fast note to another prescriber and say, listen, this is what I want to do. This is a drug interaction. How do you want to work this out? Should I look for another drug? Do you want to look for another drug? How do you want to do this? Just so that we don't end up harming this person by not communicating all of the things that can happen. Covering the cost of antiretroviral therapy, we did talk briefly about. They're very expensive. A month's supply of Biktarvy, for example, is about $3,500. That is not sustainable. I mean, maybe you could put it once on your credit card, but you can't sustain that for a year. We have to have systems in place to help people. And so many people, especially older adults, where you have the Medicare spend down, where you get X amount of money to cover, and then you have to go into that donut hole thing where you don't have any coverage until you accrue X amount of debt, and then they cover it again. There has to be a way to manage that. And as a provider, that was something we struggled with all the time, just to make sure people could get the medication that they needed. So in terms of older adults, open communication about sexual activity. And especially, I think that there must be a new mandate now for primary care providers to check for syphilis in everybody. Because I will tell you, in my last year of work, I was seeing all kinds of people in their 50s who came in with their hair on end saying, "What do you mean I have syphilis?" And they might have had it for years. And we would try to track down their partner or all their different partners and say, what's going on here? And say, listen, I don't know how this happened. I have a pretty good idea how it happened, but I don't know how it happened to you or who happened to you. But we need to treat this. And the problem too is that, of course, we always worry about tertiary or neurosyphilis. And there are some providers who are pretty hot to trot, and if you come in with syphilis and you have no idea how long you've had it, they want you to have a lumbar puncture. And I think if you come in and you've got the ringing in the ears and the headache and the night sweats and you're feeling crummy and that kind of thing, then yes, you really do need to have a lumbar puncture, because you may need to have IV penicillin for a couple of weeks. On the other hand, maybe you don't, I don't know. Just checking for things like syphilis on a regular basis. Testing, we want to offer testing every 3 to 6 months, especially if they're on PEP and PrEP, and I'm going to talk about those in a minute. Early initiation of ART. It is critical. Just because of immunosenescence, we want to get people onto treatment as soon as we possibly can. Coordinating with other providers, the electronic medical record can be my friend. If they can afford the meds, and then AIDS service organizations. And we have a number of service organizations. Every larger city, I think, is required to have one. In Worcester, we have AIDS Project Worcester. Although if you're living with HIV, you're probably getting your care either with us at UMass, maybe with Family Health, or at Edward Kennedy, and they all have excellent case managers and pharmacy liaison who can work very hard. I love our pharmacy liaison. They walk on water, as far as I'm concerned. They could get blood out of a turnip if they had to. They can get meds covered. So I want to talk now about pre- and post-exposure prophylaxis. So what is your risk of getting HIV, of acquiring HIV? Okay, abstinence. You're not going to get anything. Mutual monogamy, and we hope that your relationship makes you very happy. Now using a condom, performing oral sex with a condom, and some people will, because condoms are, you can still acquire HPV. I do have people with oral cancer from HPV, so vaginal sex with a condom, topping, insertive anal sex with a condom, bottoming with a condom, topping without a condom. All of these things are pretty low risk right here. Where you're getting into trouble is topping or bottoming without a condom, and sex while high, not asking people's status. Multiple loads means having sex with multiple people in a short amount of time. The guy who acquired Truvada, acquired HIV while taking Truvada, the PrEP, he had been on the party circuit and had sex with multiple people in a short amount of time. So it's entirely possible that he was exposed to somebody with HIV whose virus was resistant to his PrEP, and that's why the PrEP failed him. So what is the risk? The risk to the woman, receptive vaginal sex, is about 1 in 1,000. The risk to the male is less, because it's really only the tip of the penis where the skin is thin enough for the virus to get through. Receptive anal sex, bottoming, 250, because the rectum does not stretch that much. The vagina is meant to pass a 10-pound bowling ball worth of baby. The rectum is not. The insertive partner for anal sex, 1 in 500. Performing oral sex It is low. I mean, unless you've got sores in your mouth. Kissing, there was one documented transition, and I don't know how they teased out all the variables, but apparently there was only kissing involved. But apparently both parties had like a lot of oral herpes, and there was a lot of blood, and it just sounds like it was very unpleasant and not anything I would want to be a part of. In terms of occupational risk, you're about 1 in 300 with a single needle stick with HIV-infected blood in the bore. So often I'll get people who work for the city, and they'll have a needle stick because they were cleaning up in a cemetery or a park, that we've had 3 days of rain and then we had 90-degree weather. The chances of HIV being in that needle are pretty darn slim to none, but if it's a tiny little needle, people think they've been run through with a barge pole, and if people want to take the medication for that, I would absolutely offer them medication for that, because it's about control. They need to feel back in control. Mucous membrane types of exposures and are a mouth splash. Onto broken skin, same as a needle stick. Intact skin, none. So if you have a splash, just get the alcohol swab, scrub your skin, and if it doesn't hurt, your skin is intact. And we're only dealing here with the intimate body fluids, the CSF, synovial, that kind of thing. So, in terms of HIV prevention, we have to look at TASP, treatment as prevention, and then PEP, and then PrEP. So, having an undetectable viral load reduces the risk of acquiring, the uninfected partner acquiring HIV by about 99.99%. And this was part of the partner study that I'll talk about in a second. So this really underscores the importance of getting people tested into treatment early. So it's undetectable equals untransmittable. U equals U. You sometimes see people with the buttons, U equals U. So the partner study, 14 countries, 1,166 serodiscordant couples. They had unprotected sex over 3.5 years. And they reported 58,000 instances of unprotected sex, which means they're getting a lot. Somebody's getting a lot out there. HIV partner was on antiretroviral therapy and maintained viral suppression. No instances of viral transmission to the partner. So that's very impressive. There were 3 seroconversions, but the virus was not genetically linked to the usual partner. So they had sex with somebody outside of that relationship. So this is why it's really important to get people on antiretroviral therapy right away. And the importance of the relationship. You know, I want to know what's going on with your life. You can tell me. I don't stand in judgment of anybody. And believe me, there's very little that I haven't heard. Huge impact on sexual expression and reproductive autonomy as well. Because it used to be when we had a serodiscordant couple, I mean, sometimes we would refer them for sperm washing. We would put the woman onto PrEP, and we would do vaginal mucus testing. We would have her take her temperature. They would have timed intercourse during the fertile periods, those kinds of things, just to reduce the risk of HIV transmission going either way, either from her to him or him to her. But now everything has changed. It's much better. It does not affect the risk of sexually transmitted infection. So that's still out there. And it's not proven in shared drug works. People who use shared works still kind of need to be careful, because it's not been studied. It's much more difficult to conduct a study of that size, simply because people who are out there sharing their drug works have so many other issues like homelessness and the substance use and incarceration, things like that. It makes it much more difficult to do a study with that population. Doesn't mean it shouldn't be attempted, but it's going to be a lot more complicated. Now, post-exposure prophylaxis. So this is using antiretroviral therapy to prevent HIV infection after an exposure. And the FDA recommends either Biktarvy, 1 pill once a day, or Truvada plus one of the other 2. So you're taking 2 pills once a day. It has to be started within 72 hours. When they first started to look at PrEP, they did a couple of studies. They did one in Brazil, and they did one in South Africa. And they studied people who had had unprotected sex, and then they offered them the opportunity to take medications. They treated people for a week, for 2 weeks. Sometimes people didn't come in a week or two after the exposure. And what we found is that the medications have to be started within 72 hours. And one of the test controls they did was they looked at simian immune virus in macaques, in monkeys. And so they exposed the monkeys, the macaques, to simian immune virus, either intravenously or on mucous membrane. And then they did blood tests and tissue tests, and they gave the monkeys medication. And they decided that 72 hours is the absolute outside limit. If it's after 72 hours, there is no expectation that the medications will work. And as with anything, the sooner you start treatment, the more likely it is that it's going to be effective. So 72 hours sort of at the outset, and then 28 days of medications, which can be an awful lot for people. If there's been a sexual assault, if there's been a bad needle stick, maybe bad decision making after a night of bar hopping on a Friday night, that sort of thing. I saw an awful lot of that too. But it will reduce seroconversion risk by about 95 to 98%. Why is it a little bit less effective than the PrEP? Possibly because people come in and they will tell me what they think I want to hear. And even though I will ask questions, people will stretch the truth a little bit, to sort of feel more protected. I mean, I'm not going to call them out if I think, if somebody comes in and it's 73 hours and they really want the medication, I'll say, fine, I think that there's a possibility it may not work and you may have side effects, but if you would like to try this, we can do it. If somebody comes in and it's 84 hours, I'm going to say, it's not going to work. You're just going to you might feel sick from this, and I can't, in good faith, do this to you. And then we want to do follow-up testing at 6 and 12 weeks afterwards. In terms of counseling, protected sex until the first negative HIV test. So we have baskets of condoms. We hand out condoms quite freely. I used to be able to get like glow-in-the-dark and flavors and colors and things like that, but we get them from the DPH and they don't give us fancy ones anymore. But we just encourage, and I keep my friend Mr. Woody, and I just talk to people about how you put a condom on, and if you haven't used one in years, we can do this. No blood donations, and most blood donor rooms, if you've had an exposure, will not take you for about a year. Breastfeeding generally okay. The baby will be getting the antiretroviral medication because it will be coming through the breast milk. No sharing of personal care items, anything that could have blood on it. No risk through sharing a bed or a bathroom or anything like that. I had one guy working in a cemetery. He came in November and he moved into the garage, an unheated garage in November, because he was terrified he was going to give it to his kid. I said, no. You go back in the house, you hug that baby, it's all going to be fine. So understanding the risk is through intimate body fluids or if there is visible contamination with blood. So people are totally freaked out, and we do a lot of kind of supportive intervention. In terms of PrEP, the whole umbrella of PrEP. People come in and they say, well, I want PrEP. And I'll say, well, do you understand what PrEP is? Yes, I'm going to take a pill and I'm not going to get HIV. I said, let's start with PrEP 101. Safer sexual practices, awareness of your partner risk, awareness of potentially infectious body fluids, latex condoms where and if it's appropriate, circumcision, more of a market in developing countries. You can't really sell it too much in North America, but in some developing countries, the surgical van is coming around. The guys will walk for miles to have a circumcision because they know it's going to reduce their risk of acquiring HIV. It may not be safe for them in their own country to negotiate for safer sex. Oral medications that we use. Truvada, which can be given to women and to men. Or Descovy, which is kind of like son of Truvada, only for men. Descovy has not been studied in women, which is ridiculous because we give Descovy to women to treat HIV in combination with other medications. But nobody studied it formally, so the FDA says we can't guarantee that it's going to work for women. And the reason that I put it as XX and XY is because I have so many trans women and trans men that I see. So it's just, I always say, what sex were you assigned at birth? Are you an XX? Are you an XY? I don't care how you present yourself now. I'm happy to support you, but I need to choose the right medication for you. So oral medications can be taken daily Or if you don't want to take it daily, and if you're not sexually active very often, there is PrEP on demand, which is 2 tabs the day of sex and then 1 on each of the next 2 days. And that seems to be just as effective in terms of protection as taking it every single day. And that's probably because you're getting a pretty good load of medication with the 2 tablets together. And unfortunately, most insurance companies don't want to cover Descovy, and Descovy is much safer in terms of kidney health than Truvada is. So for oral PrEP, we'd like them to have minimal risk for a couple of weeks before they get tested. For a baseline test, I'm going to do HIV, Hep B and C. I'm going to do an RPR for syphilis. I'm going to check their kidney function, and I'm going to check a pregnancy test. Hep B vaccine, if they've never received it or if their surface antibody is not protective, I'm going to recommend that we give them a booster now and then another one in a month. I tell people hepatitis C gets all the good press. Hepatitis B, we can't cure. So you really want to get your vaccines. You don't want to get hepatitis B. And then I'll see people every 3 months for people who are on oral PrEP. And we'll do repeat testing. And if they're taking Truvada, I have to check their creatinine as well. But I'll do the HIV, Hep C, and a syphilis test, and whatever STD testing needs to be done. And I do 3-point testing. I'll do a throat swab. We'll get a urine. I don't really want to probe anybody's urethra unnecessarily. If it hurts to pee, then that's enough. And I will do a rectal swab as well, depending on what sexual activity people have been involved in. Now, the new kids on the block, the cabotegravir. Now, Cabenuva is the cabotegravir rilpivirine given to treat HIV infection every 8 weeks. Cabotegravir is called Apretude, is given intramuscularly every 8 weeks after a 2-month lead-in of 2 injections 4 weeks apart. So you have your 1 injection, 1 4 weeks later, and then every 8 weeks. The labs must be done prior to each injection, a 4th-generation test and a viral load test. And people come in looking for their injection, and we have a little wiggle room. I have a week on either side. If they come in, well, I didn't have time to get the labs. You need to get the labs done today. Come in tomorrow. We'll give you your injection tomorrow. I can do the rapid test. But it's critical because we don't want to give somebody a single medication for HIV when we know that it takes at least 2 to control it. And I don't want to induce resistance mutations to anything. So they have to have the labs test done first. Every time people come in, depending on what they've been up to, I'll be checking for STDs, the 3-point testing again. And we could do a 4-week lead-in of oral cabotegravir, which is called Vocabria. I had a fellow show up wanting to go on to Truvada or Descovy. And I said, great, we'll test you, we'll get you started on it. And he rashed to the point of angioedema. I don't know which component of the Truvada or the Descovy it was, so I certainly wasn't going to challenge him again. So we ended up putting him on the Vocabria for 4 weeks because I said, I cannot, in good faith, give you an injection without knowing, seeing what your reaction was to the other ones. We have to check you first. So fortunately, he tolerated it, and now he's on the cabotegravir. And then the newest one, lenacapavir, LenPrep, everybody's got an acronym. It's called Sulenka when it's used for PrEP, and it's 2 injections into the abdominal tissue every 6 months. So they did a couple of studies, Purpose 1 and Purpose 2. Purpose 1 was 8,000 cisgender women, so women who were born as women, presenting as women, in South Africa and Uganda, and it was superior over oral medications. So in other words, they only had 2 seroconversions, 2.4 seroconversion years out of every 100 years. The oral was a higher rate of seroconversion, probably because of difficulty taking the medication, having maybe to hide it, having to access it, things like that. And then Purpose 2 was 4,600 cisgender men who have sex with men, trans men, so now we're looking at trans men with the XX genotype, and women, and non-binary individuals in North, Central, and South America and in Thailand. And again, it is very effective. It's almost 100% effective. It's a subcutaneous administration. So a nodule will develop at that point, which is slowly absorbed. It's almost like a depot, kind of, like depot injections, Depo-Provera. It's 1.5 mils, which is a pretty good amount to put in a subcutaneous injection, and it's 2 doses. The cost is about $28,000 per patient per year, $2,300 per month. But we're not doing labs every month. You know, we're not having people getting sick every month. So really, this is, I think, very cost effective. Initially, we would give people a couple of tablets to take with the first injection, and then 2 tablets the following day. And then the next injection will be 26 weeks plus or minus 2 weeks. So it's every 6 months, and it is incredibly effective. Some people, we have to tell people everything about the medications that we're giving. So I say, there's a slowly absorbed depot. So you may see on your belly something. This is sort of what it would look like in the tissue underneath. Some people don't want to see that. They would rather have the cabotegravir. Fine. Whatever floats your boat, whatever makes you feel safe and protected, this is what we will do. Also, doxypep. This is something relatively new. So this is doxycycline 200 milligrams orally within 24 or up to 72 hours will help reduce the risk of acquiring syphilis, GC, or chlamydia. The problem that we have here is that we are looking at possibly the development of resistant strains of STD, and then what do we give people after that? Because I've already had to treat people taking doxypep. I've had to treat them for syphilis, even though I know that they're taking it. So, it's something that is recommended. If it's recommended, that is something that we have to offer, but I do put a caveat on that and say, you could still get this, and it may be more problematic to try to treat it successfully. So, really, you think about what you're doing. That's all. I'm not your mother, but think about what you're doing. So I want to just talk briefly then before we close about a cure or lack thereof. So we know about hematopoietic stem cell transplants. We know about the Berlin patient, and the donor had that CCR4 mutation. Same thing in London. In 2017 in New York, the recipient had acute myelogenous leukemia and was of mixed race. I don't know why they felt that was important to include, but there it is. But the stem cell transplant was from umbilical cord blood and had the CCR5 mutation. And then in Oslo, the donor had the same mutation. The recipient had bone cancer, but the donor was the recipient's brother. So they can't have been identical twins, otherwise the other person wouldn't have had HIV in the first place. So the donor had the mutation and gave it to his brother. So now his brother has a mutation because of the way that the hematopoietic stem cells work. So, latency reversal agents. So they're looking for a way to wake up dormant viruses so that they can be attacked by the medications. And if they do that, then they are hoping to wipe out the reservoirs within the body. Looking at immunotherapy, neutralizing antibodies to recognize and neutralize several of the HIV strains. Gene therapy to modify immune cells. Therapeutic vaccines, but vaccines, as I've discussed, they really don't work on RNA-type viruses. They work on DNA-type viruses. And then immune checkpoint inhibitors. So basically, they're reinvigorating the T cells to amplify their fight in the virus, and then potentially reduce or reverse the latency. So there is a lot of study going on now, very much at the cellular level, to see, working with antibodies, working with the immune response in itself, inducing inflammation in the latent cells, just to try to trigger the virus to be more susceptible. And if we can do that, if we can wipe out those reservoirs, then yes, we have the potential to actually cure HIV. And lastly, just, it has been a very long, strange trip. Despair. I mean, everybody, giving somebody an HIV diagnosis was tantamount to saying, do you have your will? Have you said your goodbyes? What would you like to do with the last few weeks, months, years of your life? We learned a lot about hospice care. We learned a lot about how to support people through end of life, how to work with survivors. And actually, now a lot of the work that we do is with long-term survivors and long-term survivor guilt. But the shame, the stigma, everything is still persisting. You know, we live in a country where Pride Month is, people get more upset over Pride Month than they do over so many other things that are worth getting upset over, like hungry people and homeless people and things like that. But, you know, basically, sort of my thought about going through life, we're all fellow travelers here, so how can we make it easier for people? What can we do to make it more pleasant? You know, what can we do to make our little piece of the planet a little bit nicer, a little bit safer, better for people than when we left it? You know, feed the birds once in a while. That's nice. You know, be nice to people, smile at somebody. That's all it takes sometimes. You know, you may have changed somebody's life irrevocably because you're nice in a way that they didn't expect or anticipate. So this is a list of the references, or partial list of the references that I used when I was preparing this talk. Thank you. I have to say, it's been such a privilege to be part of this.